I know that you would like to not transfer the frozen embryo and go straight to a fresh egg collection, but it's against the policy. I know that you would like to have a double embryo transfer, but you don't fit the single embryo transfer policy that we've got. When sometimes we're seeing things in that embryo that we understand that they would benefit from a double embryo transfer. So the goal is not consistency. The goal is not reproducibility. The goal is maximizing the chance of success of every single patient. And this means that we shouldn't, as healthcare professionals, be treated like machines, like consumables. The consumables and machines, they need to follow a specific standard. I want to know that that egg collection needle that has a specific diameter. I want to know that when that CASA machine is measuring the speed of the sperm, that is an accurate speed. But when it comes to us making clinical decisions, we need to take a holistic approach that understands what are the needs of that individual situation in front of you, that person, that sperm, that egg, that embryo. And that is where I think it's time that as a field that we evolve, because not only are we compromising the chances of this patient reaching their reproductive goal, we are also stagnating the innovation in our field as a whole. When we're following just standards and we're following that prescription like a recipe to bake a cake, we are missing the opportunity to learn from other healthcare professionals. We are so blessed at Avenues that we have amazing professionals that came from different clinics and came from different backgrounds. I'm not going to tell Oana sitting here in the middle. Oana has done so many biopsies. She was trained in the US, right? A place that does a lot more biopsies than you do here. I'm not going to tell Oana how to do a biopsy. She's better at biopsy than I am. I'm not going to be giving her a prescription of how to do it. I'm going to give each healthcare professional the general rules that we need for compliance, the general rules that we need, but they can mold that to the benefit of the patient. At the end of the day, does what you're doing bring value to the patient? Do it. If it doesn't bring value to the patient, don't do it. And if your policy goes against what brings value to the patient, change your policies. Okay? And that's it. So this is where I think individualization in this day and age is better aligned with what the patients need and want.
Wonderful. Thank you. With this, we are moving to the current setup, right? Let's go through procedure by procedure. And we earlier today heard about the oval pickup. Oval pickup procedure, it is done by clinicians. But I know, especially here in UK, there are a kind of appetites to this procedure be performed by the nurses, for example. How that is changing the procedure, the standardization, or how that is actually challenging the individual treatment of the patient. Another procedure, a great example, is embryo transfer procedure as well. It is done here in UK by nurses and sometimes by the clinicians as well, right? Gloria also, again, they gave a nice example of the standardization of the sperm assessment, how it is important nowadays in the light of the new enrollment, and how it can help actually to standardize the sperm assessment for the lab to decide, is this sperm is good and I should perform classical IVF or I need to have ICSI. All of that, current situation, what is your opinion? I would like to start with you, Chris. What is?
I say empower the nurses as much as possible. Nurses are amazing, especially in a bedside manner. So especially in that empathy and connection. And, when you're doing egg collection, it's not just about how many eggs you collected. It's not just about whether the speed of the time that you did the procedure. It's whether the patient felt heard throughout that. What was their dignity throughout that process? What was their experience throughout it as well? That matters, because in the patient journey, we all know it's not about one cycle. Most of them are doing more cycles. And a lot of them quit before they go to subsequent cycles because the stress of it all was too much. So we need to have a better approach of determining who does whatever procedure it is, whether it's egg collection, whether it's transfer, based on competency, not based on titles, based on your ability to perform that duty to the best ability or to maximize the chance of success to the patient. So this means who does whatever role, If the nurse is competent at doing that role, they should do that role. And if a doctor is the competent person to do that role, the doctor should do that role. So we need to identify, not based on titles, but on competencies. I'm a big supporter of let's empower nurses generally. We had actually an interesting case last week where an American patient came to us and she was like, I'm having this discussion with one of your nurses. It was a discussion that in my cycle in the US, I had only with a doctor. And at first I was like, why do you have nurses doing this role? And after her experience going through, she then came back to say, I understand now. I had great care, and it was really nice to see Therapy's presentation this morning. So I think it was really nice to see that you guys are following this. We know the data from the Welsh clinics that the recovery rates, I think, were slightly higher with the nurses, wasn't it? That presented this on the BFS. So the bedside manner really matters, and nurses are really good at that. And the doctors have an amazing role to play as well. So I think I would not restrict nurses from doing roles that they're perfectly capable of performing.
Thank you so much. What audience is thinking? What do you think about the individual and standardized approach? And which procedure part do you think needs to be standardized?
So obviously I come from a clinic where every single patient has an individual approach in our clinic. So it's very different. Their bloods are measured every day. Their stimulation is different. They come to us because they know KRGC does things differently, whether it's add-ons. And Christina, I 100% agree with you. It's about that patient, their history, what's best for them and that area as well. So I think that's absolutely the crux of the thing, that you assess each patient individually, give them what is relevant. And Bina's presentation was amazing. Loved the patient care and the journey. But the only thing I would agree with is that same thing, X, Y, Z. You have three things you offer. I mean, there's a role for everything and everybody. And obviously, if it's a first-time patient going through a process, fair enough. But when couples have gone through and you've had an unsuccessful round, there are things to learn, there are things to change. May not be for everyone, but for many of them, there is something to consider. So that's important. In terms of the competency procedure, I agree with Christina. Yes, empower everybody. I still think egg collection is a surgical procedure with a risk. And someone who has surgical training and experience, in my view, is important for the collection. Embryo transfers, absolutely fine. Train them, watch their competency, quality control, all of that. But egg collection, I still feel needs to be restricted to doctors, but that's my view.
May I add to that? Because this is a good point that you raised. Actually, in my country, it's not allowed that the nurses or biologists could do an invasive procedure on the patient. Embryo transfer is not a problem, but as soon as it gets to, puncture some organ, then it's a no-go. So this is maybe unique in Dutch-speaking countries as well as in the UK.
Hi, I'm more of a question rather than a statement. I actually want to ask the panel a question, because you talk about individualization and protocols, and I'm very cognizant of the fact I've got 10 clinicians and about 100 enrolled students. And I do not want to go into the debate, having done all of that with clinicians about, nurses' role, doctors' roles, should be doing twice a day blood. Let's leave the clinical aside, because a lot of arguments. I'm interested in the following. Can you give me your opinion about should there be individualized patient approach within the lab? For example, should different patients in the same lab have, you decide as the one embryologist, you use a different culture media, a different incubator, a different X-ray, a different needle. What do you think about the role of individualized care within the same lab for different clinical settings? I'm not talking about if you need VGT or not. I'm talking about culture medias, different incubators, different needles, different ICSI injection rates, different biopsy weights for different patients, not different practitioners. What's your opinion about that level of individualization? Should we have it, or should we go with what you're already doing and stick with what you've been doing for the last 15, 20 years that we're talking about? That is where my interest is.
I would suggest that a low responding patient has a needle that has a double normal. So this would be sort of an individualization. Maybe every clinician has his preferred equipment. Once it comes to the lab, actually I would recommend to use at least 2 culture media, which would mean to split the risk if there is a problem with the lot and you only realize it weeks later if there is no clinical pregnancy or no healthy pregnancy. So I'm a fan of splitting the risk. So at least this would be sort of individualization, although it's not per patient. It's just, yes, A versus B. The only thing that I know from my research is that certain patients with oocyte activation problems might need different approaches to activate the oocyte. So this is the only individualized approach that I know. This has been published by Mohamed Fassi from Egypt. He found out that one thing that I really don't believe, that those with a lower rate of fertilization in one cycle might benefit from strontium chloride. So I do not think that we should use that in human. But he also found that if it's a male problem, if it's a male subfertility and you have no fertilization due to the sperm, then it should be calcimycin or ionomycin for the oocyte activation. So this is something that you should know in advance, or you could know. And the other thing is some of the patients do need the double stimulus for oocyte activation. So this is very special, it's very a niche population of patients, I would say, but at least a little bit of individualization as I see.
With Thomas, am I allowed to be on the debate on the same side as you, or having multiple culture medias in the lab does reduce the risk. So this is something that is useful and goes against the whole standardization. It's actually you're on my side now. So that I think is something to consider. But also, some embryologists like pipetters like this, others like pipetters like this. Some like to use the RI station for ICSI. Some like to use an Arashigi. Some like to you need to make sure that your team is comfortable with the tools choice. What you don't want is that you bring somebody super experienced into the lab and you say, adapt yourself to fit this box that we've created for you, right? Because there might be some things that you end up learning from that person. So for instance, when I learned how to perform ICSI, as I moved on to another clinic and so on, I eventually met a Spanish person who showed me a completely different way of doing ICSI. And for me, I had done the ICSI that you go to the middle of the egg and you come out again. And he did all the way through what we call the kebab, almost screwing the other side. And I was, what are you doing? Should we have a policy against this, right? This was the gut instinct of like, are you good? But turns out that his spurt rates were higher. So I started training on his technique and learned how to perform his technique, which was better. Now you have the American way, right? Which makes everybody's heart stop. You go in the big swirl with your ego, right? And I mean, this goes against every gut instinct. But for some embryologists, that's their technique. So there's many little things in the way we vitrify, the way we pipette, the way that if it doesn't harm the value to the patient, allow that destandardization, if that's a word, allow that ability to choose what makes you more comfortable. I do ICSI with the, where I cross my arms and it's all on the wrong side. Rabbi knows, and every time somebody goes to ICSI after me, they go, oh, I've got to now put everything on the other side. It's not a rule that you have to have things on this side or that side. So it doesn't affect the patient outcome. Let the embryologist be comfortable with their choice. So I believe in personalizing not just for the patient, but for each healthcare practitioner as well. And in our we also have the extra challenge that we're like the home of many doctors. Yeah. So let them do whatever they like, as long as they don't breach HFEA, as long as the patient's informed of all the risks, there's proper information to the patients. So if they're using treatment options that I wouldn't necessarily want my daughter to have, but that doctor and that patient between them deciding that's what they want, it's not up to me to interfere in that conversation, right? I just make sure that we are regulatory compliant and information coming through. Like it or not, we couldn't get agreement in this room what are the right add-ons to use. It's more of a belief religious system than science a lot of the time when it comes to do you use PGTA, not use PGTA, do you use intralipids, not use intralipids, there's a lot of discussion on this. So I believe in personalization and allowing the things to happen that might not have been my personal choice.
Sorry, so is as far as a summary to say, because what you said about procedural person individualization, totally agree. What you said about risk in the lab and mitigating risk with having splitting A, B, C, whatever, totally agree. But apart from the very, very niche of the occasional activation issue that we mentioned, if we put, because I love a debate, and the title of the debate is individualized patient approach. So if we put the word patient back into it, is it fair to say that there's nothing in the lab, apart from what you just said, patient specific, not specific to the practitioner, that you would individualize if you have, you should then therefore keep to strict IVF protocols in the lab. Because that's a debate.
Okay,
Right? It's
I'm
not
gonna
about
give
the lipid. It's not about how you like holding the ICSI wig. It's about the patient.
I'm going to give you
That
a
was the
really
question.
clear example.
So I want to see what you feel about that. Yes or no?
But
Because that's
I'm
the
going to
option.
go from patient to sperm, if that's okay, the sperm representing the poor patient. So what we have at the moment is we have protocols that are standardized to say you're going to do the swim up and you leave it swimming up for 15 minutes, or you're going to put it into your Zymote and you're going to leave it for X amount of time, right? So what we have at the moment is an ability to use AI to be able to look at not for 15 minutes, but they are assessing the sperm centrally, how many have reached the destination. And if you leave it too long, then your good sperm is going to be diluted by the slower sperm that came later. You leave it too short, you don't have enough sperm in that sample. So having an ability to have an AI-driven assessment of that sperm centrally being collected, with then the bridges closed the moment that happened. Now, for some patients, that's going to be 2 minutes. Others are going to be 20 minutes. Some will need an hour, some are 10 minutes. So that 15-minute standardization is not taking into account the individualized approach of each sperm. So that's an example where standardization goes against kind of best interest so by allowing the flexibility, you actually personalize to the individual patient.
But that's still standardization with a range. It's not going completely against also. Really what is sorry, is there is a degree of standardization, of course, in all the lab procedures. Yes.
Yeah, but
I'll just ask you.
I think that's your point. You want us to claim that there is no way of individualization on a patient basis. But one more example, at least we have two small examples. There is also the chance that, you fail in a cycle, so that embryo development is not as you want to have it. And then I would automatically next time maybe choose a global culture media instead of a sequential one or something. So I react on a failure. But first something has to happen, so that makes my mind change. From the very beginning, I agree on that. From the very beginning, you don't have any idea which patient needs which culture medium, which, yeah.
There is individualization in the lab, per egg, per embryo, per sperm, as Cristina said. But obviously, we would follow the standard protocol. It comes with experience on how you're going to treat a really thin zona egg that, I don't know, is very sensitive and it's oval. But, we have, 200 of them in one day to individualize on, and you may not be patient specific because each egg will be different and it will be from the same patient. So we obviously follow standard rules and protocols, but if an egg is not as an egg looks in a book, we will be more gentle.
Hi, I'm really enjoying this debate actually, and there's so much to unpack. I've got so many comments in my head, but I just want a mixture of what you said. I think people, just myself and Carol this morning, we were talking about like our dream lab, and we both said, experience. Imagine if everyone in the lab is experienced and they all knew what they were doing. What's the reality? We live in Dublin. There's not a lot of experienced embryologists in Ireland. Everything can you just talking about, our lab and the ratio of trainees to experience. I mean, the idea of having a bunch of experienced embryologists that know what to do. Hey, you go ahead and you biopsy and how we best see fit within our protocol. Like you were saying, the egg there's different shaped eggs, there's whatever. That all comes down to experience. So if we had the dream lab, the dream team, everyone is experienced, they use their common sense, all of this kind of stuff, great. But what's the reality? I mean, the reality of introducing different consumables in the lab with different culture medias. I'm just thinking now, with the lab manager hat on, like, what a chaotic nightmare. And then even with the quality hat on, in Ireland, it'll be the same in HPA as well, like the consumable tracking for each patient, we need to note down what batch lot was used with every single thing that touched and made it. How do you do that with all this personalized different consumables and approaches? So I'm really sitting on the fence. I want that lovely individual. I'm going to do the best from all my experience, and I know that the reality is how do you manage that?
Wonderful. And that's actually drive us to the last point of the debate. What is the future, right? What we would do in terms of the questions and the discussions that we are having here, how the future technologies will challenge variables, individual approach, or the standardization.
I wanted just to answer your question first because a very, very good point. Is Alison Campbell here or no? Well, I was Alison's trainee, so Alison will tell you what it was like having Cristina Hickman as a trainee in the lab. Okay? And
That's why she left.
that's what she meant. So, Addison kind of empowered me as a trainee to have a voice in that lab. Even though I was the most junior one, I was the one that got the coffees to everybody. I was the one taking the liquid nitrogen tank outside, but all the tasks that ended up along with the trainee. But I was there also bringing the change to introduce time lapse, bringing on blastocyst culture as opposed to cleavage transfer, looking at, oh my God, when I was in the IVF lab for cows, I had reduced oxygen. Why are we cultured atmospheric oxygen here? So we had this culture of being able to have a voice no matter how inexperienced you are. It was the same time when I was at Boston Place. I'm going to mention Tom Wilkinson, those of you who know him, he's with Fertility now. Tom Wilkinson was our trainee. He introduced so many changes in our lab operationally, and he had just come out of an MSc from university. It doesn't matter how many years experience you have. It's a way of, are you giving them processes to follow, or are you creating people-based approach, right? So yes, you've got this is how you do X, Y, and Z. That's the trainees will follow the instructions for, but they will be the best ones with fresh eyes to turn around going, but why do we do it like this? Especially with the new Gen Z, Gen Alphas coming in. Listen, because they'll come in and sometimes there are things like, man, I've been in this for 25 years and I never noticed that. This seems so logical now that you say it. This is just the way we did it before. So don't worry about the fact that you don't have everybody with a PhD with 20 years experience in the lab. It's not about that. Empower them with getting a PhD over time and going to visit other clinics. They're welcome anytime over at Avenues, for instance, to come and visit and see what other places look like and bring back those ideas, even though they've only been working for 6 months in embryology. So that's just for that. Coming back to you, I think what we have as a next generation is AI, holotomography. We're not just looking at time lapse and looking at the individual cells and morphokinetics. We're now looking inside each individual cell and tracking each individual mitochondria inside each cell. We are now entering an era of robotics and AI. Whether we love it or hate it, it's here to stay. And this will create a whole new era of personalization, which we will need these technologies to be able to deliver. It's going to give more empowerment to our patients. It's going to give a better understanding what's going on. It's going to give us a better way to interpret and make clinical decisions. Like it or not, the tools that we have today, some of them are not fit for purpose. Like the WHO guidelines, the WHO standards that we have at the moment. This was just a population-based looking at its fertile and infertile. We're using it to make decisions whether they do IUI, try naturally do ICSI. It wasn't designed for that. So we need better tools, data-driven tools that will give us a better way to make these clinical decisions in the future.
Yeah, you make the point. The future is more robotics and automation, I guess. And I see that as a two-edged sword. So there's a lot of risk. Not that we will be replaced in 1 year or the other. It's more like the way they do it right now, referring to the IBM online paper on the first 5 growth. There are so many things that the robot doesn't do. So you still need someone doing all the steps. There is no control at all so far. at least to my knowledge. So I'm a little bit afraid of the future. And on the other hand, I also try to represent Azure. So I was board member of Azure. I'm still active. I was in charge for the RCC program in Ireland. I'm also active in the certification of embryologists. So yes, follow your guidance. I really recommend to train your staff properly, trying to get them certificates, make them use their brains. Sometimes they are afraid to ask us, so they do realize something is strange. They have no idea why this is the case. So it's your part. It's up to you to explain it to her. And if you don't know it, and most likely you won't know a certain special phenomenon, but use your network, try to get an answer, get back to the literature, find a solution. And if you can convince your trainees that you did your very best to come up with an answer, then they will really stay forever with you. And with those who don't want to stay forever, you know what to do. No training.
Thank you. And with everyone else, I'm a bit sort of torn between both sides, and it's a balance, isn't it? That, you know, it's evidence, it's risk, and it's responsibility between all of those things. That the standardized approach works for the majority of patients. If we have the evidence that something differently individualized, as Thomas said, from previous cycles or from the medical history, then we provide an individualized approach. And it's the same with the introduction of automation. The evidence is really key, and we've got to implement it responsibly, because validating it from this big data that's published into your specific clinic, it's really difficult. And so far, we struggle very much to validate a lot of the automation to bring it into clinical practice.
Can I just add to that? Because that's a really, really important point. The validation is something that we need to also personalize the validation. At the moment, the HFEA is collecting what should be the KPI to choose a fertility clinic, right? And the options they gave us is per embryo transferred, per cycle started. That's not in the best interest of the patients. And we can give you all the little shortcuts where if you want to rank higher, this is what you could do on each of those KPIs. We should never be in a position where one decision will give us a higher ranking and another decision is in the best interest of the patients. It should be a KPI which is on a per patient basis, not on a per treatment basis, right? So the examples of, do we leave that embryo in storage, or do we move onto another fresh egg collection? Do we do dual stem? Do we do 3 egg collections leading to the same cycle? Do we cancel the transfer because this embryo is slow and would fare better in a frozen cycle? So all of these decisions affect on a per treatment cycle. What does a patient care? Is how much what was the cost to baby, what was the convenience to baby, and what was my time to get to that baby? Those are the David Sable's KPIs. Those are the 3 things that the patient cares. So we really ought to be asking the HFEA to rethink what their KPI should be. The ones that they're proposing at the moment are not aligned. This then leads to RCTs that are asking the question using these traditional KPIs that are not aligned with what is in the best interest of patients, which is why PGTA doesn't fare well in RCTs, which is why we have AI-driven tools, and any embryo assessment, whether you have one arm with, one without, that's not how the tool is used. The tool assessing an embryo is not going to increase its chances of implanting, but knowing what is the potential fate of that embryo can help us across multiple cycles make better clinical decisions for the journey of this patient. So definitely we need better validations and mitigation of risk for each new innovation being introduced, but we also need to change the way that we measure success.
Just kind of add to the same thing as Rebecca was saying. Overall, I know if I went in the lab and how to standardize, to kind of come back a little bit to Venus' point about trainees, I think in some ways every embryologist for all procedures should be following a protocol, and there's certain things we can control. We can't control, like, let's be flexible with where the XC controllers are and how exactly a biopsy is done or how we inject an individual egg. That's experience as well.
But there is a protocol. There's the timing of the stripping, the timing of the injection, what our dish prep look like, how controlled we are in our dish prep, that every individual is doing the same thing so we can stand over it. Because ultimately for KPIs, it's all dependent on our variables. And if we're not controlling the variables, then our KPIs, if they drop 1 month, so we'll, if you're assessing every month and they drop, what changed? So we have to have like a huge amount of control in our operators, how they perform everything. And I think for trainees in particular, we found at least the minute details, we have to be quite precise on our training, handling, everything, timings. And I don't know, I think it all fits into it. So it is standardized in a lab, and we follow instructions well, and there's room for some flexibility. And I think that's where the evidence comes from. I don't think we'll have evidence unless we perform in the lab in a standardized way.